Okay, well, ladies and gentlemen, Mr. Chairman, it's an honor and a pleasure for me to talk about, I think, a very difficult topic, and some of it has already been touched on by the previous speakers. And my challenging topic is to determine what is the right indication. Now, as you know, that's open for debate. So there is a big question mark around or after what is the right indication. And I'm not sure whether after my presentation we will have established that right indication. Let's see if this works. It does not. Technique seems to work now. Thank you. So as I said, the right indication, the question mark, and I think that it is still a question mark, but we will look upon some of the data that we have now. Is it working? We'll do this manually. So as discussed by our previous speaker, mechanical solution for stroke in non-valvular atrial fibrillation. 90% of the strokes related to AF come from the left atrial appendage, so a mechanical solution for that seems very appealing. And if we look at the data that we have, most of that comes from the PROTECT AF endpoint analysis. And as was mentioned before, the efficacy of the Watchman, or in this case the Watchman, was non-inferior to oral anticoagulation, and also the all-stroke occurrence was non-inferior to oral anticoagulation, and that I think is the most important data that we have at this stage for left atrial appendage occlusion. Now let's look a little bit more at the data, and let's look at what type of patients were actually in that trial. The age of these patients is rather high. They are 70 years on average, predominantly male, and they have congestive heart failure, a history of hypertension, high age, and a previous transient ischemic attack or ischemic stroke. So this is in fact a high-risk patient, and in this trial patients needed at least one risk factor to be included in the trial. If we look more closely at the CHADS-2 scores, then we see that actually 70% had already 2 or more risk factors. So in this trial, most patients actually had a much higher stroke risk because they had at least 2, and in most cases even more CHADS-2 risk factors. And if we look at the type of AF, which is also interesting, then we see that this is a mixed population. Patients with paroxysmal atrial fibrillation, about 40% of the population, and about 60% of the population had persistent or permanent atrial fibrillation. And all had preserved left ventricular ejection fraction. So I think we should take these things into account when we try to extrapolate data from the PROTECT AF to the general population that we see in our hospital. Let's look at the consistency of the data of PROTECT AF across subgroups, and there are several subgroups that were looked upon. Females, as was already mentioned a little bit earlier on by Professor Kem, with drugs or oral anticoagulation, female has received a higher risk score. In this trial, a female actually had a very large confidence interval, but it was a consistent effect also in females. Age, both above and below 75 years was consistent, and also CHADS-1 score was still a consistent effect that it was better or that it was non-inferior to the device, and also in 2 or more risk factors. So across all these subgroups, it seems to be that the effect of the Watchman was non-inferior. So the evidence is that in a population of a CHADS score with 1 or more than 1, it's non-inferior to oral anticoagulation. It includes any type of atrial fibrillation, as long as it's non-valvular, and it's consistent for all the subgroups that we were shown. But as was mentioned, there was an initial problem with the implant, because the implant also poses a risk which has to be taken into consideration as well. Now, the guideline that we have currently on this, and much of the guidelines has been discussed by Professor Kem, but at this stage, this is the European Society guideline, which at this stage actually only says that it is something to consider, left atrial appendage occlusion, in patients, mostly where there is a contraindication to chronic anticoagulation therapy. So, so far, non-inferiority does not seem to be good enough to accept left atrial closure as a alternative. Now let's have a look at the CHADS-2 and the CHADS-VASC score as an indication for left atrial appendage closure. This is a small case that I wanted to present to you. This is a 60-year-old female patient with acenocumarol as oral anticoagulation on sotalol for paroxysmal AF. She also had some mild mitral insufficiency. She had flutter, for which she received a cava tricuspid isthmus ablation, which was successful. But then it turned out that she also had symptomatic paroxysmal atrial fibrillation. Her CHADS-2 score was 0, and her CHADS-2-VASC score was 2. And the question obviously is, which of these options would you choose? And we don't have to go into the detail to let everybody choose, but there are obviously options here to consider. Should we do aspirin? Should we use the CHADS score? Should we use the CHADS-VASC score to determine our stroke risk? Well, the CHADS score has the well-known scoring system, with stroke having 2 points, so it's a higher risk complication. And if we look at, again, at the PROTECT-AF data, then left atrial appendage occlusion criterion was at least one risk factor, although it was, in both cases, it was non-inferior to oral anticoagulation. But with the CHADS-VASC score that we use now in Europe, this becomes a little bit more complicated, because now we have 3 additional risk factors that are have to be taken into consideration. If we look at the actual treatment now, we see, as pointed out, that with a CHADS score of 0 and also with a CHADS-VASC score of 0, no antiplatelet or anticoagulation therapy is recommended. But with a CHADS score of 1 and also a CHADS-VASC score of 1, we now prefer oral anticoagulation, or in some cases aspirin. And with 2 or more, both in the CHADS and CHADS-VASC score, we do need to use oral anticoagulation. So at 2 or more risk factors in both risk scores, there is an absolute hard indication for oral anticoagulation. If we look at the risk, however, we see that with the CHADS-2 score, at a risk of 2, or with 2 risk factors, the stroke rate is 4%, which is 4% stroke risk is a CHADS-VASC score of 4. So if we now look at the recommendation where we go to a CHADS-VASC score of 2 as an absolute oral anticoagulation criterion, that risk is actually much lower. So we're moving into an area where oral anticoagulation is prescribed much earlier at a much lower absolute stroke risk. So if we look at that score, then the evidence that we have from PROTECT-AF, then the evidence starts at a risk factor of 1 or more, but the majority of AF patients have at least one risk factor, and there is only a hard indication for oral anticoagulation at this stage if you have more than 1 risk factor. So this would seem to point in the direction that left atrial appendage closure should actually be considered at 2 or more risk factors. With the CHADS-2-VASC score, we actually do not have any evidence because that has not been tested, so we extrapolate this from the CHADS-2 score. And again, here the hard oral anticoagulation indication starts at more than 1 risk factor, but at a much lower absolute stroke risk. So if you base it on stroke risk alone, then it seems to be that left atrial closure should be considered here at a stroke risk at 4 or more risk factors. So that is obviously a question mark where we should take that cutoff point where we would consider left atrial appendage closure over oral anticoagulation. So in this case, in this patient, we started Coumadin therapy based on the CHADS-VASC score of 2. We did not consider left atrial appendage occlusion, but we also performed left atrial ablation for atrial fibrillation. The other question is there a high-risk subgroup that we could identify that is more in need of left atrial appendage closure? This, for instance, is a 76-year-old female patient on acenocumarol and amiodarone. She had a TIA and hypertension as risk factor. She had no coronary artery disease and normal left ventricular function. And she had recurrence of TIAs in 2011, and that was under, even under oral anticoagulation. Her CHAD score was 3, and her CHADS-VASc score was 6 in this case even. And again, the question obviously here, what should we do? Should we give aspirin, Coumadin, or a new anticoagulation drug, or should we go for left atrial appendage occlusion? Well, again, if we look at the data that we have from PROTECT-AF, then about 20% of the patients had a prior stroke in the PROTECT-AF group, and many of these patients had a history of at least 1 or more years of oral anticoagulation therapy. So a prior stroke or embolism is probably the most powerful reason for a vigorous stroke prevention. So this population actually seems to be at the highest risk because they have already proven that they can make emboli that can move to the brain. And if we look at the stroke risk of patients with AF, then you see that once you have had a stroke, then the risk of recurrence is much higher if you have AF than if you do not have AF. And also the mortality in patients that have had a prior stroke is much higher at 30 days and 1 year. So this patient category that have suffered a stroke seem to be at the highest risk and seem to be a population that, at least in my mind, is very eligible to receive left atrial appendage occlusion. In this patient, we indeed performed left atrial appendage occlusion, but we also performed an AF ablation, which we combined in one procedure, and I will get to that a little bit later on in my presentation. The other question is does AF type influence the benefit of the therapy? And as I just showed from the PROTECT-AF, about 40% of the patients had paroxysmal atrial fibrillation, and the other patients had either persistent or permanent atrial fibrillation. And in PROTECT-AF, the non-inferiority of left atrial appendage closure was consistent for all these AF types. But I want to point out to a small, or to a sub-study of Aristotle, which was presented at Heart Rhythm as a late-breaking clinical trial, which was the trial apixaban versus vitamin K antagonists. And in this case, they looked at the type of AF and then looked at the effect of stroke prevention. In this population, 15% of the patients had paroxysmal atrial fibrillation and 85% of the patients had persistent or permanent atrial fibrillation. These patients were slightly older, slightly more often male, had more often heart failure and a higher CHAD score compared to the paroxysmal patients who had more often myocardial infarction and hypertension. And what they found was that the persistent and permanent AF patients had a higher rate of stroke and embolism compared to the patients with paroxysmal atrial fibrillation. So here the question again is raised whether it is AF burden or type of AF which is responsible for a higher stroke rate, or if it is only risk factors that are associated with the higher stroke rate. So that is also a question that in my mind is not yet solved. Now, the other thing which we have to take into consideration when we look at patients is the bleeding risk, which has already been discussed also. And nowadays we have the Hasblad score for that. We know that oral anticoagulation may reduce the stroke risk by 66% or 70%, but a lot of these patients, they refuse to use oral anticoagulation because they think that indeed it is rat poison. And a lot of physicians even do not want to prescribe oral anticoagulation for the same reason. The patient compliance is poor, the INR needs checkup, and bleeding is obviously a risk with these drugs. The Hasblad scoring system consists of high blood pressure, abnormal liver and kidney function, stroke, bleeding, a labile INR, elderly patients over 65 years of age, and interaction with drugs or antiplatelet drugs or alcohol consumption. Let me look at another case here. This is a case of a 67-year-old male patient who was on acinocumarol, and he has bleeding problems because he has Rundu-Osler-Weber AV fistula malformations. And he has had a lot of bleeding problems because he had nosebleeds and even bleeding from the liver, and he's had a lot of treatment for that. His CHAD score is 1, which makes oral anticoagulation at least an option. CHADS-VASc score is 2, and from this CHADS-VASc score, oral anticoagulation is actually indicated. But his Hasblad score is 3, and he obviously has had bleeding under oral anticoagulation. So in this patient, again, we need to figure out what type of treatment we should give to the patient. If we look at the risk of Hasblad scores, then we see that at a Hasblad score of 3, the risk of bleeding is around 3.7%. And this is considered to be a significant bleeding risk also in the guidelines. And interestingly, obviously, age, hypertension, and stroke overlap with the CHADS and the CHADS-VASc score. And if we look again at 2% or at the risk factor of 2 in CHADS-VASc score and the risk factors of 2 in the CHADS-VASc score, then we see that there the stroke risk in the CHADS-VASc score is about 2.2%. And if we now compare this to the Hasblad score, then you see that with a Hasblad score of 2 or more, the bleeding risk is around 2%. But with the CHADS-VASc score of 2 or more, the stroke risk is also around 2%. So here we arrive to a difficult balance where there is an indication but also a contraindication for oral anticoagulation. And this obviously is, I think, an interesting patient population again to look at the position of left atrial appendage closure. In this patient, we did perform a left atrial appendage occlusion, also because the patient had bleeding under oral anticoagulation, a high Hasblad score. So in our mind, this was a very clear indication. This patient did not receive an ablation because he was in accepted permanent atrial fibrillation. The ASAP registry has already been shown. These are data that actually show that it is safe to perform a procedure like that. I will not go into a lot of detail because that may happen later on again. But these were all patients that had a serious problem with bleeding in several ways, overt bleeding, also history of hemorrhagic tendency, and all these patients had problems with that. And if we look at the reduction of the left atrial appendage occlusion over, let's say, the effect that you would expect with these CHADS score, the CHADS score was about 2.8 in this patient population, then there was a significant reduction in events when you position a left atrial appendage occlusion compared to what you would expect from real-world data. So this seemed to be safe with an anticoagulation strategy of clopidogrel and aspirin at until 6 months, and then continuing aspirin beyond 6 months. Now, the last thing I wanted to mention is, does rhythm control matter? Does it matter how much AF patients have and if you're really able to treat AF? That's obviously also a difficult topic. This is a case also from my practice in a 47-year-old female patient who was on ACE inhibitors and furosemide and acinocumarol. She came in with persistent AF many years ago. She also had hypertension and some heart failure, and she had mitral regurgitation of more than grade 3 based on dilatation of the left of the annulus of the mitral annulus. When we cardioverted her and put her on sotalol, she became paroxysmal and her mitral valve regurgitation diminished. We performed a pulmonary vein isolation and she actually became free of atrial fibrillation. At least she did not have any more complaints, and on the Holter that we did not see any more atrial fibrillation. And this went on for a couple of years, and she came back for a couple of years and she had no history of AF anymore. And we said, well, this is nice, no AF anymore. The mitral insufficiency is gone. CHADS score was 1, CHADS-VASc score was 2, but because she had no AF anymore, we decided, well, what should we do with the anticoagulation? Well, in this case, we stopped the oral anticoagulation, but just recently I learned that she had a recurrence of palpitations and she actually had a stroke before she could come back to the cardiologist, even with a relatively low CHADS score. So the problem is that even though we may be able to treat the rhythm, that does not always mean that we are able to prevent the complication. If we look at RACE, which is a trial from more than 10 years ago, we also see that rhythm control with antiarrhythmic drugs still is associated with thromboembolic risk and also is still associated with bleeding complications. So it doesn't really matter whether you do a rhythm control strategy. And the same is probably true for atrial fibrillation. This is a, I would say, sobering perspective from Bordeaux, where they looked at a 5-year follow-up of patients after ablation in a mixed population of paroxysmal and persistent AF. And these patients, a lot of these patients had a recurrence of atrial fibrillation. So you never know whether AF is really treated and whether your stroke risk really goes down. Also, if you do a repeat procedure, and this is from data from our own center after surgical ablation or catheter ablation, even if you do a repeat procedure, you do not know whether this will lead to effective treatment of atrial fibrillation. And also we have to take into consideration the procedural complications in PROTECT AF. So that's why we decided to, in our hospital, to go for a population of patients that were either had a history of stroke or bleeding or had a high CHAD score, and combined this in most of the cases with an ablation. And these are some data that we have here. This is 54 patients. The age is actually much lower, it's about 65. But these patients had an average CHAD score of 3, or median CHAD score of 3, and a median CHAD-VASc score of 4, and a Hasblad score of 2.5 mean. Many of them were on Coumadin and Therapin. Also, many of them, about 1/3, had bleeding problems. 1/3 of them had had a stroke, either while even using vitamin K antagonists, and about 40% had a contraindication for vitamin K antagonists. So this is also obviously a higher risk patient population with bleeding problems. And we combined this with ablation in most of the cases. This went well. We did not have any procedural complications. We were able to implant the device in all these patients successfully. And if we look at the follow-up at 6 months, then our biggest complication was that we had one device that embolized, which we could retrieve from the groin. But in all the other cases, we had a successful implant. We did have some small leaks in some patients at the beginning, some of them closing after some time, but we did not have any problems during the follow-up with stroke or TIA, and we only had some problems with patients that developed bleeding because they were still on oral anticoagulation. So in Holland, we now have a consensus statement, and that's the last slide I'm going to show, where we state that the left atrial appendage closure has a role in prevention of thromboembolic complications in patients with atrial fibrillation, and that we consider this in the following situations. Patients that have an indication for vitamin K antagonists, but a history of significant bleeding, or a Hasblad score of 3 or more, or a history of stroke with or without vitamin K antagonists. And also patients with a CHADS-VASc score of 4 or more. And we think that it may be performed in combination with an ablation for atrial fibrillation, which will be discussed later on again. But we obviously need more data in the real world to show how this effectively works in the real world population. And I think I will end with that. Thank you very much.